And but there are something. I'll just go through a brief that where is infant mortality. Infant mortality has come way down, way down in last 30 years compared to the world. Yes, definitely, but we are still lagging behind the Western world, and now we are somewhere around 25. Infant mortality has come down, but the neonatal mortality is still the major chunk of the infant mortality. It was like somewhere around 70% to start with in 1981, and still it is 70% only. It is there, neonatal mortality. And in this neonatal mortality, it depends on a lot of circumstances. First is family income. Those with the lowest, those belonging to the lowest strata are the sufferers. So IMR is as high as 53. That is thrice compared to the highest this thing, family income group. First is this. Second, there's a difference in different states. Those states called Bimaru states, Bihar, Uttar Pradesh, Madhya Pradesh, Jharkhand, those northern central India, they suffer more compared to those like Kerala. Kerala has achieved a IMR as good as any Western country, and compared to Madhya Pradesh and Uttar Pradesh, that is as bad as sub-Saharan countries. So India is very. And see, one thing is those states with less resources are doing better than those states with good resources also. So it's a mindset also. It's not just the poverty. It's a mindset also. In this infant mortality, when you see this graph, more than 50% is neonatal mortality. So there, if I say an infant is dying, out of 100, more than 50 are neonates. And most of them is neonatal preterm birth, the causing of mortality, the cause of mortality, followed by parental asphyxia, then infection, then other causes of neonate like jaundice or hypoglycemia. But majority is preterm birth. So if you want to come down on parental death or neonatal death, then the preterm birth has to come down. The preterm care has to come up. Then, when we say neonatal mortality, see, we divide into first early neonatal mortality, late neonatal mortality, and then infant mortality. Early neonatal mortality, 0 to 6 days, accounts for more than 50% of infant death. And out of 0 to 6 days, first 24 hour account for at least 50%. So 25% of infants do not see the first 24 hours of life. So it is something to be thought of. 25% of babies don't see their 25th hour of life. Those who die. So, and this, you see, preterm birth and neonatal disorders account for almost 50% of all infant deaths throughout India. This is NHFS 2023 data. It's a very recent data. It's not changing. Other things are pretty much stagnant. This thing, infectious diseases are coming down, especially in the higher income states, but preterm birth and related deaths are almost similar in all the states across India. It has to be taken care. India is the largest, in fact, largest neonatal population, preterm population of the world. India accounts for almost 25 to 30% of preterm population of the world. And that is one important thing that we have to think of. Combined world preterm, 30% are with India, and with the highest mortality. Highest mortality, it accounts for 8% of preterm 8% of preterm births result in death in India. So almost 1 out of 10 preterm who are born in India do not survive. And that's a big number. It's a very, very big number. in compared to, when we compared to high income groups, the lower middle income countries, when it is a peri-vival age group, till the time they're 24 weeker, it is similar. But once we come to 25 weeker, there's a lot of difference. 25 weeker survive 75% in a high income group. But in India, 25% high income group, 75% survive. In India or low middle income countries, 25% survive. So those 50% preterm are potentially salvageable. And we should concentrate on this. Concentration means prevention of prematurity. There has to be a strategy how to deal with this preterm birth, where these deliveries should happen, and after delivery, how to take care of them. That is important. What we have to focus on is a preterm birth and complication, the early neonatal period, very early neonatal period. Those from the rural background, those from the lower income group, those with having some neonatal infection, they really bear the burden of major neonatal mortality. When we see world over, our antenatal coverage of India is around 50% still. And compared to 2012, that was yesterday, till today, we have not made much progress in it. Compared to the Western world, that is nearly 80 to 100%. That has to come up. The coverage of antenatal care has to come up in a big way. Something has to be done, especially in the peripheries. Periphery doesn't mean, periphery of Northeast India. It is the periphery of our own Delhi, UP, Madhya Pradesh. They are the periphery. Still, if you go to Moradabad or somewhere in Bareilly, they still do not have a good antenatal coverage. And that has to be taken care of. The real mortality is here, and they're not far away. They're not far-flung places. They have good roads. They have good highways. But the connectivity is there, but connection is not there. The connection with the doctors, the trust on the doctors, and last minute connectivity, that is lacking. The skilled birth attendant, those are attending the delivery, the number is increased. And where we are doing good, where we are still lacking is postnatal care. Postnatal care. The maternal mortality has come up. That's a good thing. But postnatal care has not improved. It was 50% 2012. 10 years down the line, it has increased to somewhere around 55, 60, not more than that. So when the baby is delivered, that's fine, but they have to be taken care later on also, especially the first 28 days, at least the first 7 days. And we see those baby coming in a neglected situation. They're not counseled properly sometimes. Sometimes the parent do not know. And since they're connected with the gynecologist for a long time, it is our job to connect to them, tell them that this 15, 20 days are also quite crucial. Now there's the phases of newborn care where the mortality comes down. The Western countries have achieved this phase 4, where the neonatal mortality rate come down below 15. They achieved somewhere around 1980. China started slow. It was pretty similar to India in 1990, but suddenly dropped, and the rate of decline of neonatal mortality was, it is humongous. It should be appreciated. So they were sitting somewhere around 35 in 1990, and by late 2000, 2005, they came to 12. That is comparable, even same as Western countries. India started similarly, but somewhere we got lost. Right now in 2020, we are at somewhere around 23 to 25, the NMR, and we have to come to 12, that is phase 4, phase 5, predicted to be 2030, but still we are stuck at 25, even in 2026. So we are lacking somewhere here. So when we say the neonatal mortality, how much we have come down to, we have come down 25%, from somewhere around 60% to 25%. But thing is, we have stuck at 25% like now. Uh, in India, if we say the child mortality, this early neonatal period accounts for 50% still. And it was not that initially that postnatal mortality was there, 25%. The child mortality was 30%, and 30% was early neonatal mortality. Now this late neonatal mortality has come down. The child mortality, the pediatric care has really improved. But neonatal mortality, the mortality has come down, but the proportion of neonatal mortality has not decreased. Thing is, what is not improving is over, relying on the government infrastructure, and that is not improving the big way, at least in neonatology. Second thing is, neonatology is a very costly business. I don't think so a middle class can afford neonatal care for more than 20-25 days unless he has to sell his property. That thing has to come down. There have to be some innovative ways, and there have to be some non-invasive ways also. There have to be prevention of neonatal infection, the prevention of prematurity, that has to come down. The risk benefit has to be taken in very seriously with the gynecologist. It has to. Now sometimes we are very scared that if there is in utero death, we are not scared of the ex utero death. Believe me, there are much more ex utero death than in utero death. Those we delivered just saving our skin, they do not survive later on, and that is a problem. I must not push the blame. Yes, if the baby dies in utero, that's a big issue. But somewhere we have to sit down with the family and tell them that you want a baby and how to get to we have to have a balance between the death inside and outside if you do not blame us, and clearly document it. In the past, when we say stillbirth, in the past 2 decades, almost 48 million babies were born stillbirth. Low middle income countries constitute to 84% of all these stillbirth. India, with almost 1/4 of the population, contribute to almost 25 to 30% of stillbirth. 40% of stillbirth occur after onset of labor. And most of these stillbirths are preventable. Just we have to find out that where we have to take action, how to strengthen our system. And strengthening of system means strengthening of our nurses, the training of the nurses. That is quite important. What my experience with neonatology is, I rely on my nurses more than my residents. I have trained my nurses small skills, and they are very sincere with it. Small things. That sister, if the perfusion comes down, and I've explained them as in simple points. Perfusion means stop scoring for me, sensorium, temperature, oxygenation, pulsatility index. Pulsatility index is a beautiful marker. We will talk about it later. It's just a pulse oximeter. It gives a pulsatility index. And if the pulsatility index comes down, that's an indirect marker of decreasing perfusion, poor perfusion. And that gives indication of shock, that predict shock are almost 12 hours. That predict infections almost 12 hours earlier than our CRPs tell us. Non-invasive, every nursery has it, but nobody looks into it. We have to extrapolate the data. When we compare to low to middle income countries, high income countries, see the difference. In the previous slide, low income countries have almost 10 times more stillbirth than high income countries. We also, the lower middle income countries, where India is 1 out of 60, is a stillbirth. And we are at least 6 times higher than the Western countries. Even compared to China, we are almost 3 times higher. And China started recently. Even since some African countries like Egypt, like South Africa, all the South American countries, they're doing much, much, much better than us. Much, much better than us. So stillbirth rates are pretty high in India and they have to be taken care of. So there are two things, neonatal mortality, stillbirth. And as far as we know, almost 40% of stillbirth are preventable. There have been a decline in stillbirth thanks to efforts from the gynecology team everywhere. The stillbirth rate are coming down. India also have 50% reduction in stillbirth in last 20 years. But the problem is the stillbirth was decreased between 2000 to 2009, and now the reduction is lesser. When we see Central and South Asian countries, there is no further reduction in stillbirth. It is just 3.0, so 3% reduction in 2000 in 10 years before, and this 10 years now. Every other country is coming down. The world overall has come down, but our stillbirth rates are just similar. This thing we have to take care of now, the stillbirth and the neonatal. We'll come to the real topic, the leading cause of preventable neonatal mortality. Prematurity, at least 50%, 15% asphyxia, then some metabolic causes like hypoglycemia, hypothermia, jaundice, and infection. Sometimes we do not counsel the family properly. Sometimes we do not counsel them antenatally also. Sometimes, and most important, what I feel, we do not inform our gynecologist that this child needs follow. And this should be done. Whomsoever I have ever called a gynecologist, madam, this child has to be taken care of. They really, really take care and they tell, please come on a follow. And and parents have the parents have been seeing the gynecologist for 9 months. They have deep belief in gynecology. तो एक बार अपने नियोनेटोलॉजिस्ट या पीडियाट्रिशियन है उनसे बोलना जरूर है कि कुछ भी होता है यू लेट अस नो. एक तो मेंटल वो रहेगा कि हाँ गायनेकोलॉजिस्ट थिंक अबाउट द बेबी एंड रियली 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 फिर वो फॉलो अप भी अच्छा करते हैं. व्हाट आई हैव सीन. So these communication is the key also, and we really sometimes lack on this communication. In Amrita, luckily we are not in a blame game mode, and we communicate openly, and that's how I think so. It's helping us. PIGO has PrEP 5 initiatives, and they recently in 2023 they published this 5 interventions that will help us in decreasing, that is a perinatal intervention that will decrease neonatal mortality. So I think there's no controversy about it. Antenatal steroids have to be given. Magnesium sulfate has to be given in all babies less than 34 weeks. There has to be delayed cord clamping. There has to be breastfeeding. So this is a breastfeeding week going on. I should be happy in telling that everybody is celebrating breastfeeding. A sad part is less than 60% are doing exclusive breastfeeding. So 40% babies are not getting an opportunity to have exclusive breastfeeding. Not breastfeeding exclusively increase the risk of mortality by at least 20-30%. And in preterm, increase mortality by at least 25-30%. Kangaroo mother care, it's a no new thing, everybody knows about it. But now things is mother NICU is coming up. Mother NICU is just the mother should stay in vicinity of the NICU where the baby is admitted and should take part in care of the baby. We have started a mother NICU in Amrita, and what we have realized, the mother is nearby, the nurses work better. The nurses get confidence taking the baby home, and they do contribute, and the cost comes down because there is a nurse called the mother of the child She's free, dedicated, work extra hours, and only for her baby. Infection rates really comes down. So I can remember they were baby of Swati. They were twin. She was a nurse, and she could not afford, Amrita NICU, and it's still a cheaper NICU, but still costly for a nurse. We made an arrangement for her that you will have to stay here, do a double shift for your baby, and your nursing charges will be off. That really worked for us. And those twin baby born 25 weeker, they were extubated within 2 days, and they are 2 years now doing absolutely well. So that is how we can collaborate with them. All other nursery also, I think so. If they teach the mothers, this mother NICU concept is a very good thing that should come up, and that should be the future of neonatology. Neonatology in my PG time, we didn't have good ventilator, and I was like, I'm not a complete doctor. I'm not a complete doctor. I don't know ventilation. I do not have a good access to good ventilators. So I joined neonatology. I learned ventilator. Now the thing is, we are coming back. Those who are using ventilator too much, I think they are not good neonatologists. It's vice versa. Where I started, I was thinking that if I'm not using a good ventilator, I'm not a good neonatologist or a good pediatrician. Right now, I'll say if you are using too much of ventilator or using too much a good ventilator, then you are not a good neonatologist. It is getting non-invasive, non-invasive, non-invasive. Babies as small as 500 grams do sometimes, frequently, at least 40% do not need. Those babies more than 800 grams, 90% time do not need ventilator. Uh, those babies more than 800 grams. 800 gram is somewhere around 27 week. 27 week and above, 90% will not need ventilator unless there is a complicated course, or if the baby was asphyxia, or the baby has severe IUGR, something like that. Otherwise, they really do not need ventilator. Those babies who have a delayed cord clamping, even preterm babies, they are doing better. They need less resuscitation. They need less blood transfusion. Their IQs are better. They have a lower BPD. They have a decreased IVH. Term babies should always be given delayed cord clamping. Preterm babies more than 32 weeks, if you cannot do a delayed cord clamping, intact cord milking should be done. In preterm babies less than 32 weeks, try as much as possible to do a delayed cord clamping. We suggest 60 seconds, if not 60, something at least. Something at least. Now we're going to come up with some controversies like steroid in less than 34 weeks, no controversy. No controversy about choice of steroid. I think everybody is wise enough.
Please mute. Somebody's is noise coming.
Betamethasone is not to be used in India because the salt betamethasone phosphate plus betamethasone acetate is not available. Only dexamethasone, nothing else. Nothing else. The concern is the neurodevelopment part and how frequently can we repeat. So there was a trial in 2016, steroid for late preterm, steroid late preterm. We found out they have a lot of benefits. And asymptomatic neonatal hypoglycemia was increasing. Now, there were an action trial, WHO action trial done in lower middle income countries. They found there was no difference. Then there was a stress trial, early term elective LSTS. They found there are benefits. But they did not tell us how much benefit. The early term elective LSTS, how many of them go to nursery? Very few of them. Is it that there's an intervention? There can be there can be reduction in RDS. Definitely can be reduction. The relative risk can come down. But how much? Is it worth taking that cost? multiple repeat dose of steroid, they found that yes, the lung disease sometimes comes down, but not always. So it's Acto RDS in 2006 said that there are a reduction in RDS, but then MACS in 2008 says there's no benefit. So there is definitely a benefit in less than 34 weeks. Late preterm is a subgroup where there is a benefit. Term elective LSCS, no much benefit, and the side effect of neurodevelopment are higher. Similarly, in low middle income countries, does anti-steroid work? Is there an increase of chorioamnitis? So this was the Action 1 trial. They said, yes, they do work and there's no increased risk of chorioamnitis. WHO Action 3 trial is coming up in future that will decide, can we decrease the dose of steroids? Can it be a lower dose of steroid? And is there a difference? Now, thing is, this question is coming up. Should we be using steroid? Is there a long-term neurodevelopment outcome? There are some neurodevelopment impairment coming up. It is not in the intellect, but it is in the behavior of the children. So, where those babies who need steroids should definitely get it, because Indian nurseries are still not ready to handle very sick babies. And that is, I'm talking on behalf of the best of the nurseries. We are still not ready to take very, very sick babies. So we don't want much babies in NICU.
Oh my God.
Much babies, because those babies who goes into NICU, goes for RDS and come back with sepsis. And that's the real problem with all the nurseries, because it's not a money-making business. So a hospital do not invest much on this. Antibiotic stewardship is poor in India, really, really poor in India. We don't want our babies to go to NICU. More than 36 weeks, I hardly see much babies coming to NICU for RDS. So more than 36 weeks, I don't feel a need of steroid. Those babies in between 34 to 36 weeks, if your NICU is very good and the risk of sepsis is very less, then I think so we should not be using it. But if you do not have a very good NICU in your proximity, or your NICU's outcome is not very good also, then we should definitely consider using steroid, considering the risk-benefit ratio. So in late preterm, the RDS rate or NICU admission rates really, really come down. There is a small risk of behavior impairment in those, but you have to tell the parent and you have to explain that if the baby develops sepsis, there are risk of mortality, and there is a risk of later behavior impairment later on that we have to take in consideration. So there was this recently published studies in 2004 that how much the impairment is. So there is some impairment, 4% increase in composite long-term outcomes, those term babies who received antenatal steroid, then those babies who did not. So there is a positive association in term baby, definitely. So late preterm, we can consider if your nursery is not that good, or if you feel there is a risk of sepsis, or if your parents are not affording, definitely. But term, I will say we should wait for more evidence. Then one specific thing that we neonatologists tend to suffer. Sometimes there's a lot of thing going on that late preterms are near terms. Late preterms are not near terms. So death under 1 year, if we say 50% are late preterm, they are the largest subgroup that end up in mortality, 49%. If we say that those babies who are late preterm and term, and late preterm constitute to about 60 to 70% of preterm birth in India. So they are the single biggest bunch of babies who do not see their first year. That has to be taken care of. Late preterm are not term. They have a lot of issues. What you can see is their size, but you cannot see what goes inside. The brain maturation the sulci and gyri are really formed after 32 weeks. The brain at 35 weeks is almost two-thirds the brain of the size of 40 weeks. There is a lot of autism associated or behavior abnormality associated with late preterm delivery. There are a lot of breastfeeding difficulty. Those babies who are admitted to NICU for more than 72 hours, more than 50% of them do not achieve breastfeeding. Those babies who do not achieve breastfeeding, definitely there are 5 to 10% decrease in IQ. We are not seeing them. There is a lot of hypoglycemia in late preterm. The threshold for jaundice for late preterm is higher. Their blood-brain barrier is not matured. So subtle, damage to brain happen with even certainly high jaundice in this late preterm subgroup. There are multiple morbidities further, like hypothermia, hypocalcemia, respiratory distress. But we don't like. I don't want to stretch it further. But late prematurity should not be, it should be an exception. It should not be a routine. It is as bad as a stillbirth. It is as bad as a stillbirth. Please do not electively deliver at 36 weeks. Special situations where there is a risk of death to the mother, everything is possible. Everything should be done. Our outcome of late preterm really has improved. But in peripheries, and especially in the NICUs which we deal with, the smaller NICUs, late preterm are the one who really suffer because they have to be admitted to NICU for a day or two, and they get sepsis there, and they come to us in a very bad shape. Very bad shape. This subgroup has to be, taken care of. This was a beautiful article just recently published this month only, August 2026, that how much can we wait for an abnormal Doppler? So they gave this, that there is a time between abnormal Doppler going to a further stage of abnormal Doppler, like a increased resistance in umbilical artery. Usually takes 7 days plus minus 8 days to become intermediate absent and diastolic flow. Then this intermediate absent diastolic flow usually takes 6 plus minus 6 days for a complete persistent absent diastolic flow. Then further, almost 6 days to intermediate reverse end diastolic flow and 4 days for a reverse end diastolic flow. And if we wait for this, fetal death is in intermediate absent end diastolic flow is 1%. In absent end diastolic flow is 2%. In intermediate absent reverse end diastolic flow is 1.3%. In a reverse end diastolic flow, it increased to 11%. 11%. So there are a lot of, death do not happen that early. So what we have to see, we have to increase the monitoring of the mother rather than delivering the baby very early. There is no guideline in the world which says that whatever abnormality the Doppler is, apart from ductus venous changes, that we have to deliver before 32 weeks. Only if there are late ductus venous changes, we can deliver as early as 26 weeks, or if there are STV, short-term variation is abnormal, or there is an abnormal biophysical profile, we should be holding on. There is a lot of trial that went. There was a grit trial, there was a truffle trial that showed that early delivery do not help, and those were in Western countries. In India, where neonatology is still in infancy, we are not ready to handle those babies who are 26, 27, 28 weeks in majority of setup. 32 weeks, they will survive, but they will have to pay a lot, and the sequelae is going to be high. So this is the same article which says that how much it takes from umbilical artery increased pulsatility index or more than 95% to become to a reverse end diastolic flow. It is like 18 days. 18 days. We have to take care in all these things, increase frequency, but do not get panicked and deliver it immediately. Madam, we were just discussing, there was a baby who was about to be delivered at 27, 28 weeks and delivered at 35 weeks. So there was, 7 week. You know how much money the parents saved? Almost 10 to 15 lakh. That was big money. And more than that, the morbidity of the baby is really, really low compared to if the baby was delivered at that preterm 27, 28 week. See, this is a data recently published last month only in Indian Pediatrics, and that is from the good neonatology center. They are from the top corporate chains of India. No, and unlucky to say, none of the chains from northern India is there. They are either from Maharashtra, Tamil Nadu, Kerala, or Hyderabad. Here also, when we see the survival at 25 week is 50%, and 24 week is only 10, less than 10%. So survival below 27 week is not the mortality in utero mortality with the reverse end diastolic flow at 27 week is just 5 to 10% or maximum 15%. The mortality at 26 week after delivery is almost 30% in best of the center in India. Best of the center in India. And if you say the usual center, 27 week also is 50%, I will say. And they will have morbidity too. They will have morbidity too. That's what I want to highlight, that delivering a child doesn't ensure the child is the baby is going to be well and he'll survive the first year. That's there. This thing, the FIGO has given a guideline how to deliver, when to deliver, and how frequently we have to monitor. So if there is a reverse endoscopic flow, we have to monitor every 48 hours, 24 to 48 hours. Earliest we can deliver at 30 week. We can wait till 32 week also. Only if there are ductus venosus reverse endoscopic, the reverse AV, we have to deliver at 26 to 28 week. Otherwise, absent endoscopic flow has to be delivered 34 week. But we have to monitor them bi-weekly, twice in a week, every 72 hours. Monitoring is important. 1 day in utero is as good as 3 days ex utero. 1 day stay of a mother in any good corporate is 10,000 rupees. In an average corporate or a trust hospital, 1 day stay in NICU is almost 15,000. And in a good corporate, it goes as much as 50,000 to 80,000 per day. The cost of neonatology is at least 5 times the cost of mother staying in the gynae ward. And plus, there are a lot of benefits. Have an honest conversation with the family, have a written documentation. If you have a good neonatologist or a good fetal medicine with you, involve them, make a list, make a plan with the family, get them involved, get yourself medico-legally safe, but give them an honest opinion. Give them an honest opinion. Resuscitation is one thing that needs lot of care, that needs lot of training. The gynecologists have to be, because sometimes neonatologists are not there, sometimes they're not trained, sometimes they don't even take the onus because they have to come there for 10 minutes and then go. Gynecologists have to take care. They have to have a good resuscitation team there. The nurses have to be trained. These few things are essential. A delayed cord clamping, easy, safe, must do. Now, I think so. No gynecologist should deliver in a place where there are embu bags used. Embu bags are absolute. Absolute. Even in government setup, they should not be used. It has to be a T-piece that gives a delivery room CPAP. You believe me, I have not intubated a single child in last 2 years in delivery room. Not. And I go for only preterm deliveries. Even we had a child 1 month back, 26 week, 530 grams, not intubated. They stay well on CPAP. They do really well on CPAP. Intubation is a skill that has to be forgotten now. Then oxygen targeting. You should have one pulse oximeter there. You should have a blender there in your delivery room, or at least in NICU. Pulse oximeter has to be there. Saturation of 70% do not warrant an intubation. It just need an increase in FiO2. There have saturation of 75% at 1 minute of life or 2 minutes of life is okay. Okay. Prevention of hypothermia is a simple tool. Those babies who are born preterm, less than 32 weeks, should be wrapped in a plastic sheet. If nothing is available, the plastic apron that is available in all the OT should be used. This is as good as anything else. So when we give a delayed cord clamping, see, we increase the blood flow to the baby from 70%, 70 ml per kg to 100 ml per kg, at least 30 ml per kg. Baby usually have 80 ml per kg. So we're giving half of the blood to the child, extra. And those babies who are at a lower level than the placenta gets more blood rapidly. Eventually, everything equalize, but only if you want to clamp the cord early, put the baby a little lower to the placenta, and then that will benefit. Just how to briefly describe a delivery room. If you give a delayed cord clamping, it will help the uterine contraction. There will be lesser transfusion in your baby later on. There will be less need of resuscitation. The brain will be better. The IVH will be lesser. The BP will be maintained. One thing is, even in RH, there incompatibility, there is no increased risk of pathological jaundice. So there is no absolute contraindication of delayed cord clamping unless there is an abruptio placenta and the baby is really non-vigorous. We can do a delayed cord clamping in more than 32 weeks. We can do an intact cord milking, not less than 32 weeks, more than 32 weeks. If nothing is possible, at least a cut cord milking should be done in more than 32. Less than 32, only delayed cord clamping, if possible. I think so. These things, if you find a pediatrician or a neonatologist giving these things, he need to be retrained now. Oxygen by prongs, oxygen by hood is something history that was past and should be discarded. AMBU is something of past. Puff has to come up. This TPs has to come up with a blender. Because there is lot of the alveoli changes with Neopuff are better. They are better distended. Collapsed lungs are prone to cause lot of problem. I'll just show you how there is a alveolar this thing chest inflation with the EMBU. Hardly you can appreciate. Without that much of effort, with TPs, there is a good chest rise. Inflation of chest, and it is controlled. It do not cause barotrauma. When you see there is pneumothorax, always think there was EMBU used, because pneumothorax are really low nowadays. I was trained in Surya Hospital, and there in one time more than 70 preterm. I was so unlucky that we had only 8 pneumothorax in my 4 years. 1 year was extended because of COVID. Only 8, and out of 8 pneumothorax, 6 happened in a single child. I always used to feel that I'm so unlucky. I had to go to CTVS OT to learn how to put a chest tube. And this is, I think, because of using a CPAP. When I came to North India, and everybody said pneumothorax bahut hota hai. But in Amrita also, those babies who come from outside, I see pneumothorax. Inborn babies, we hardly say pneumothorax. See, this is how we resected with a TPs. This is a baby we had. The baby had a poor breathing. We just put TPs and finish. Give up. This is as good as a EMBU. We put a plastic sheet, and this is a 26-weeker baby, 750 grams. And baby saturations are going to be well with this. That's it. Just. That is it. Just relaxation for us, nothing else. We don't do anything out of the world. Just simple, non-invasive things. One thing every gynecologist has to know. Pediatrician बोल देते हैं loosely saturation 70 आ रहा है, intubate करना पड़ेगा. But see, at 2 minutes, saturation of 70 is good. At 3 minutes, saturation of 70 is good. We have to go to saturation of 85 only at 5 minutes, and that too at a right hand. You put up, pulse oximeter on the left hand, doesn't make it, doesn't help. And there has to be blender. Giving 100% oxygen is not good. So we have to give some 40% to somebody, some baby who is preterm less than 32 weeks. In term baby, we have to start with 21% oxygen. So not all desaturation, especially if they are above 70, do not need intubation. They have to be monitored there with a CPAP. One thing that has never changed in mother own milk, room air resuscitation, KMC, and new thing that has to come up is mother NICU. The mother has to stay with the child. The new innovation that we are trying to do is LISA. LISA is that we don't intubate. On CPAP only, we give surfactant. And that increases the outcome of the baby. There are innovative ways, like we now hardly prick any child. We don't take venous sample. We do a capillary sample from a prick on the finger. We make a small prick on the feet of the child. That is called field prick. And we collect sample from that. From there, we can find bilirubin, we can find electrolyte, we can see HB. Sometimes we don't prick a child, even if they stay for a month or two, we hardly prick them once or twice. The new thing, the new innovation has to come. The neonatologists have to follow. They have to learn from their juniors also sometime. The ego has to come down a little. There are non-invasive ways of monitoring, and they're easy, and they can be integrated in artificial intelligence. And there are PCR-based tests that are coming up good. I've been working on some models here, and we found out so that those babies who get referred from outside usually have antibiotic, and their culture do not show anything. Here the PCR helps. So this is the mother NICU, how it goes. The mother is lying down, the baby receiving CPAP, father is sitting beside them, and the KMC is going on with respiratory support on, and this has a lot of benefits. Breast milk is going to be kal. It was there kal. It is aaj, and it is going to be tomorrow. It prevents at least 20% of neonatal death, 15 times reduction in pneumonia, 11 times reduction of diarrhea, benefit in brain growth, lesser ICU stay. The gynecologists have to prepare the mothers when the baby is in utero to give breast milk. They have to be encouraged. They have to be told. सब यही कहते हैं दूध नहीं आ रहा. One thing I'll tell, please support them. And babies do not need much milk in first 2 days. I just tell them, we will monitor the sugar and the weight of the child. If the sugar and the weight of the child is okay, that means दूध सही आ रहा है. There's only one way to find out that your milk is sufficient. After third day, if the baby is sleeping half hour to 1 hour and passing urine every 3 hours, that is adequate breastfeeding. Passing urine every 3 hours after first 3 days. That is adequate breastfeeding. No child is going to sleep at night. Babies drink. They are nighttime feeders. They're going to have breast milk every 1 to 2 hours at night, and they might not have breast milk for 3 to 4 hours in daytime. So I don't have to be, fixed rigid. It is on-demand feeding. 8 to 10 feeding in a day. 8 to 10 urine in a day, and they will lose some 10% of the weight, and by 10th day of life they will come back to their birth weight. So if that is happening, that means breast milk is okay. If mother, and I'll tell the mother, you don't take stress. If you take stress, it is like you're decreasing your dopamine in the brain, and the milk production will automatically come down. Milk is produced in the brain rather than the breast. Have a lot of water. Do a lot of meditation if you can, or bhajan. And one innovation what West has found out is to decrease anxiety of a child and the mother is called white noise. White noise is simple, smooth music, which our ancestors were doing it, Lori. So Lori they have found out now, and we were doing it. There are a lot of traditional medicines like saunf, like traditional jo ajwain ka pani. Doctor, just forgot the name. In Australia has found out Indian traditional medicine are doing wonders in increasing breast milk. We can use them. If medicine has to be used, then domperidone, no perinom, domperidone, 10 mg TDS, lesser side effects, and better. Dr. Sanjay Patole. If you have time, go on internet, Dr. Sanjay Patole on increasing breast milk. You'll find a lot of answers. Lot of hypoglycemic gels are coming up. There has a lot of worry going on. Does it cause neurodevelopmental impairment? If we overuse anything, that cause impairment, but judicial use, those babies who has to be transferred outside, those babies who are really at a risk of hypoglycemia, who we know that they're not going to get a IV, please give a D25 dextrose, 0.5 ml per kg. This is much, can cause neurodevelopmental impairment than one single episode of hypoglycemia. One single episode of hypoglycemia can cause, serious brain damage. I think that's a beautiful innovation. Those people who have been using it, they have found out that NICU admissions, the risk ratio is 0.68. So lesser baby needed NICU admissions if we use dextrose gel in high risk population. Those like diabetic mother, obese mother, a UGR baby, preterm baby, those babies.
Madam, that time is now is 7:57. So, sir, please.
I think so. I think last slide is, ma'am, just one last slide. Extreme preterm is there. It is on a rise, and in India it is quite high. Those who are at a risk, please counsel them. Lower middle income countries or have a lot of jaundice, and that now non-invasive ways to find out jaundice is there, and their LED phototherapy. Please encourage your neonatologist or pediatrician to buy LED phototherapy with good evidence. Infection is increasing. MDROs are high. In India, a lot of infections. So please do not let babies go to NICU. I think that's the last slide of mine. So we have to integrate everything. We have to machine learning, deep learning, and integrate the team and integrate the nurses in this. Hope I contributed a little. Thank you.